Thank you very much. It's an absolute pleasure to be here and to talk to you. Last century I was doing research on melanoma, and I don't treat melanoma at the moment, but it's something that is very dear to my heart. So I hope this will be helpful to you. I've got some disclosures. So I'm a director of Oxford Lymphedema Practice and Oxford Bone Infection, and I'm an NHS consultant in Oxford, and I've got a specialist interest in orthopedic infection. So I appreciate my colleagues are really helpful. I'd like to talk a little bit about what lymphedema is, so that you've got a basic understanding of what it is. I'd like to say why it's actually important to people with melanoma and how it's going to fit in. I'd like to talk about the symptoms that people get. I'd talk briefly about what investigations are useful, but also I'd really like to talk about the treatment and maybe illustrate a patient case to explain, to bring all of that together. So we are wet on the inside, and we have these lymphatics to deal with that wetness, okay? So they're spread throughout the entire body, and the cells, your individual cells are bathed in fluid. These little pink things are bathed in fluid, and that fluid leaks out from your bloodstream all the time. You make about 4 liters of this fluid each day. So it comes out from the tiny little capillaries. It then has to get back into the blood, and the way that it does is it goes into these little purple channels called lymphatics that are absolutely tiny. They then coalesce together into slightly bigger channels, but still very small indeed. And the important thing here is that fluid then passes through lymph nodes. And lymph nodes are these little processing stations that catch infection, they catch dead cells, but importantly, they catch cancer cells. So the fluid passes through those, is processed. There are valves, which means it only goes in one direction. So here it's going to go up through the groin, up through your pelvis, up through the middle of your tummy, and that fluid rejoins the bloodstream in one of the big blood vessels in your neck. And you can see that's a very long and convoluted channel, and if there are any problems with that, then you can run into problems with lymphedema. So this is a sort of map that we work to. So you can see from your toes these little green lines that are working your way up. They go through the pelvis all the way, and the arms do a similar thing. So it goes up from the hands, it goes through your armpits, and everything goes back into those big veins in your neck. So try and remember that map. This is a little bit more detail. So the skin's at the top, the muscles are at the bottom, the fat has been removed, and you've got these little green tree-like structures, and these are the lymphatics. And the tiny little branches of these trees suck in that water, and there's gaps open up between the individual cells, so it's absolutely tiny, sucks this fluid into this collecting system, that then the fluid passes down through the branches of the tree, it goes down the trunk, and then once it gets to the bottom, it turns and it starts to move up and out of your limb or out of your trunk. The way that the fluid is pushed along is something called peristalsis. So the same way that food squeezes and gurgles down your gut, the fluid in these little tubes gets pushed along by this milking of the muscles in the wall. So the heart isn't pumping this around, but literally the tubes themselves are pushing the fluid along. So why is this important to patients with melanoma? Well, it's important because melanoma, one of the ways that melanoma spreads, it spreads along those lymphatic channels. Little bits of tumor break off from the melanoma and they spread to the lymph nodes, and they get caught in those lymph nodes. And so those lymph nodes may need treatment. And that treatment is often to remove those lymph nodes to get rid of those cancer cells. And so patients with melanoma can have their armpit lymph nodes, their groin lymph nodes, or sometimes their neck lymph nodes removed as part of their treatment. And it's the same in breast cancer or gynecological malignancy, for example. Now, the consequence of that treatment, of removing those lymph nodes, is that nice lymphatic pathway has then got a gap in the middle of it. And so the fluid that is collected in your leg or in your arm can't get out of your leg and your arm because there is a gap in that lymphatic system. So as a consequence of this treatment, of your lymph nodes being removed, if it's your groin lymph nodes and you're treating your lower leg, about half of patients will develop lymphedema. If it's your upper limb and they're taken out of your armpit, then it's about up to 20% of people will develop lymphedema. So these are large numbers, and it's the consequence, it's not a complication, it's a consequence of that treatment. In the upper limb, it's less. That's about the same as someone who's been treated for breast cancer. In the lower limb, it's actually more than if you've had a gynecological malignancy and you've had lymph nodes from inside your pelvis, because the ones that are taken in your groin are very specific to draining the skin of the lower leg. So the symptoms of lymphedema, people will notice that they get some heaviness in their limb, or they might get some swelling in their limb. It might be discomfort at the end of the day. It might be everything feels a bit tight. They might get pain. They might get tingling sensations. But the classic is limb swelling. Over time, that swelling causes other changes within the limb, and the skin becomes a little bit thicker. You get fibrosis or scarring. Everything becomes a little bit tighter. Very occasionally, you get fluid leaking out from the skin. And the most significant complication of all is cellulitis. Cellulitis is a medical term that describes an infection within the skin. And because you've got all this extra fluid sitting there, it's a nice culture medium for bugs and germs, you're at greater risk of getting cellulitis. And that is extremely painful. You might get admitted into hospital for antibiotics. It's a very serious consequence. Lymphedema is a chronic and progressive disorder, in that once you've got it, it generally gets worse over time. And one of the reasons that happens is because those lymphatic channels, they have increased pressure because they're squeezing this fluid and they can't get out the limb, so the pressure in those little tubes goes up. So when I have high blood pressure for many years, my coronary arteries fur up and I have a heart attack. If you have lymphedema, your lymphatics start to fur up over time. And so they end up being they start being normal, and then they move and they become very scarred, which means they don't transport the fluid as well, which means your lymphedema can get worse. And so this is what we see when we look down a microscope. So the left-hand end is a normal lymphatic, it's translucent, it's got clear fluid in, then it becomes swollen, it's like blowing up a balloon, and then it becomes scarred later on. And that seems to correlate with progression of the disease over time. The other thing that happens is this extra fluid that's in your limb, that environment has changed the way that cells behave. So the skin cells are insulted, and they can only do one thing, and that's make more skin cells, so your skin becomes thicker. The fibrous cells that hold you together on the inside are insulted, and they can only produce more fibrous tissue, so you become a bit tighter and a bit more scarred on the inside. And the other thing is that the fat cells are insulted, and so that they produce more fat. And so you start off with an excess of fluid, and it turns into an excess of fluid and fat over time. So this disease progresses and changes. So this is someone who's had a specialist MRI scan, and this is someone with breast cancer, but very similar principles. The hand at one end and the shoulder at the other. The red is the muscle and the sort of gristly bits. The yellow is the amount of fat that they have in their arm. And the blue is the fluid. So you can see they've got a little bit of blue around their elbow. Well, that's your elbow joint. But the rest of it hasn't got much fluid in. It's got a reasonable amount of fat. This is someone who's had lymphedema. This is their affected arm. They've had it for many years. And you can see there is a lot more fat and a lot more fluid. But actually, certainly in the upper part of the arm, most of that extra volume that's there is fat and not fluid. So it starts off as fluid. It then progresses to fat. They're treated in very different ways. So here's a patient. They kind of put this all together. He had a melanoma on his back in 1999. He had the melanoma removed. He had the lymph nodes removed from his armpit. One of those was positive for melanoma. So he had the right treatment. He got rid of that melanoma. He came to see me in 2014, so he's still alive. That's fantastic. He developed swelling in his affected right arm 6 months after his treatment. So it wasn't straight away, it was 6 months later. He's had 3 episodes of cellulitis, so that's the infection. And his arm is swollen, heavy, and his hand function is not as good. So he had a clinical diagnosis of lymphedema made. He'd been referred to his local lymphedema team, and he'd gone into compression garments and massage, and I'll tell you a bit about those later on. But he came to see me 15 years after his diagnosis of melanoma, and his right arm was 56% bigger than his left. So imagine his left arm is 100%, that is 156%. And that is quite a big difference. So that's 1.5 liters bigger. And he says, well, what can you do about it? So the investigations that we might want to do to look and make the diagnosis and also stage their lymphedema to see where they are is there's lymphoscintigraphy, which has been around for many, many years, ICG lymphography, which is relatively new, and MRI scan. And I'll explain the advantages and disadvantages of those. But really, ICG lymphography, I want to show you that in more detail because it gives really good anatomical and physiological detail. So I can see what's happening with the lymphatics. We inject a little bit of dye that goes into the lymphatics and it travels in the lymphatics. We can shine a camera at the patient and in real time we can map the lymphatics to see how well they're working. And so this is the sort of thing that we might see. And if you look, these are lymphatic channels and you can see that the dye is moving in them. That is peristalsis in action. That is that squeezing, milking process going on. So you can see that there's dye in those channels and it's getting squeezed along by itself. Okay? So that is peristalsis. That is normal lymphatics. Here's a patient with lymphedema, and you can see there's those nice deep straight lines, but also there's a big blob of dye that's just sitting there underneath the skin and not moving very well. And then as you go up the arm, there's another big blob of dye that's just sitting there and not moving. And what that is demonstrating is that there are some channels that are working in there, but they're not working perfectly. It's like a traffic jam. There's a build-up of pressure. The dye is moving in an abnormal way. So that's a way of making the diagnosis, but also working out how far the disease has progressed. The other thing that we can do is an MRI scan, and this looks at the amount of fluid and the amount of fat that's there. So we need to know what the enemy is. Are we trying to deal with fluid? Are we trying to deal with fat? And so the MR looks at these two different things, two different scans. The scan on the left-hand side is basically the fat is white and the fluid is black. And you can see on the normal limb, the smaller limb, there's a lot of white underneath the skin. That's fat, that's normal. But on the other image, the limb is much bigger and it's got all these sort of black lines in it, in where the fat should be, and that's fluid. So when I'm looking at a patient with lymphedema, I'm trying to think, okay, what is the problem? What am I dealing with here? How well are the lymphatics actually still working? What have I got to work with? And are we dealing with a problem of fat or fluid or a mixture of both? So how are we actually going to treat this? Now we know, hopefully, what we're dealing with. So the fundamental problem is this lymphatic blockage, okay, which is the green. That's the blockage. And that means that you've got increased fluid. Okay? And so there are non-surgical ways of treating this, so what we call conservative or non-surgical, and then you've got surgical. And they basically boil down into one that's going to treat the fluid, which is lymphovenous anastomosis, or liposuction, which is going to treat the fat. Okay, so there's kind of three different things going on. And so the non-surgical treatment is the standard that most people get to begin with in the UK. All right? And that is ways of physically moving that fluid out of the limb, normally with some form of pressure, and that might be a pressure garment, and there's a whole variety of different types. It might be manual lymphatic drainage, so you're physically trying to massage that fluid out, okay, to make as much use of those lymphatics as the residual function you have, but also just to physically squeeze that fluid out of your leg. People can have bandaging. You can elevate your limb, you look after your skin, you try and prevent cellulitis, and they are the mainstay of treatment in the UK, and that is delivered normally by lymphedema practitioners who are specialist nurses, but is only treating the symptoms. You're not actually treating the underlying disease process that's going on. So to treat the underlying disease process, you've got to think of a surgical technique, and that is to say, well, hang on, I've got these lymphatic channels in my limb which are working. They've got fluid in them, and they want to get it back to your bloodstream. They can't get to your neck because you've had some lymph nodes removed. Why don't you join the lymphatic onto a vein in the limb, and then it can squeeze the lymphatic fluid, the excess, back into the bloodstream in the limb that's affected. And so that is lymphovenous anastomosis, which just means joining a lymphatic onto a vein. Okay? And so you can see the green is the lymphatic. That's one of those deep pipes from those trees. The blue is the vein. You kind of stitch them together. This is done under local anesthetic. Okay? So this is me doing the operation. This is all looking down a microscope. And it's a bit time-lapse, so it's sped up a little bit. But I make a cut in the skin, and I look in the fat, in between the fat globules, looking for a lymphatic. So here's a lymphatic. The lymphatic's got blue dye in it. It makes it easier for me to see. Okay, so we're just underneath the skin. I found my lymphatic, and now I'm looking for a vein. So I'm searching around in the lymphatics looking for a vein, and there is a nice vein. So I've got a vein and a lymphatic. So cut them. So I've got two ends, and then I'm just going to stitch them together. So there's a bit of background so I can see what I'm doing. Got some very fine little instruments, a bit kind of technical sort of stuff, but basically it's very small plumbing. All right? This is a very, very small needle. And we just put some stitches in to join the two together. Right? So it sounds straightforward, it's a bit technical, but you can see the inside of you is wet, isn't it? That is lymphatic fluid, that is your interstitial fluid bathing your cells, and the skin is dry. And that's because we're all wet on the inside. So we spend a little bit of time doing all that, getting it right. We've got some little clamps on. The little metal clamps are there just to stop any flow, so it doesn't bleed everywhere. Tie some pretty little knots. Put the needle back in it, and the needle goes off, and then we take the clamps off, and I'm looking for blue dye in the lymphatic going into the vein. So that's what we're looking for. We're not looking for blood in the vein, we're looking for the blue, which is the lymphatic fluid. And so you can see the blue dye in the lymphatic is going into the vein, and so that is draining that patient's lymphedema as of now. Okay? It's small, so that was a measurement. That's 0.6 of a millimeter in size, so it's quite small. You can see a mark on the skin where we've marked them from our ICG test. There's a bit of just jiggering about to make sure it's all going to lie nicely once we join it all back together again. And then this is just normal skin stitches going back into to stitch the skin back together, and that's the operation done. So this is just to show you. And the bottom left-hand corner, that bit of metal is on a lymphatic. It's a little clamp on a lymphatic. So that's a lymphatic tube. You can see some stitches where it's joined to the top right-hand corner, which is the vein. And if you look, when I take the clamp off, you'll see the blue dye coming up the lymphatic and going into the vein. And that's what should be happening in your neck. It's happening in my neck as we speak. But actually, this can happen in your limb, and therefore you can reduce your amount of fluid that you have there. So here's back to our patient. So he comes to see me. In 2015, we did some LVAs. So we did 6 joins through 4 incisions. He comes back the year after, and he's gone from a 56% difference to a 27% difference. So it hasn't completely got rid of the lymphedema altogether, but it's significantly reduced. And so instead of 1.5 liters, he's now got 800 mils. And then he comes back in 2021, he's got a 20% difference, so he's stable. He's not getting any worse. Remember, lymphedema is this progressive disorder. He's not getting any worse, so he's stable, and he doesn't have any fluid. And he says, do you know what? That was great, but I'm still a bit bigger. What else can you do, doc? Right. We like a challenging patient. So we do the scans, and we do it again, and we realize that this is fat and not fluid, because he's had lymphedema for a long time. Remember, it's 99. He's got an extra bit of fat there. Right. So then we think about liposuction. So this is not cosmetic liposuction. This is not a little bit here and there to make you look more beautiful. This is a bit more industrial process of basically trying to remove all of the subcutaneous fat scar that's there, okay? So we call it liposuction, but you might call it a suction-assisted protein lipectomy if you're American. It's a bit more fancy. I think they charge more than we do. So, but basically, you're trying to remove that, and you're saying, well, hang on a minute. We're not trying to, the fluid isn't the problem now. Fat is the problem. And the only way I can do as many LVAs as I want, but that's not going to get rid of the fat. I need to get rid of the fat by liposuction. Okay? So we then commit to liposuction. So this is a different patient. She's had a breast cancer-related lymphedema, but if you look at her left arm, it's significantly bigger than her right. She has an operation, and we can control, we know the difference, like 800 mils, 1,000 mils, whatever it may be, 5 liters of difference between the two limbs. We can remove the appropriate amount of fat from that limb, and then the two limbs will be equivalent volume. So the graph on the top left, you can't really see it, but the first bar shows she's got a 45% difference preoperatively, and then it comes down to almost 0. And in fact, at anything, at a year follow-up, she's actually got a slightly smaller limb on her lymphedema side than the other side, which is a great problem if they come back and say, my limb's too small, doc, what can you... Okay, But that's, so liposuction is very effective and predictable at reducing the volume, okay? But it does come with people have to wear garments. So it's useful for the later stage disease where fat is the problem, but people are going to be wearing garments as well. And so this is back to our patient. He's had his melanoma, he's had his LVAs, he's come back for liposuction. We've done a liposuction. So we take him from a 20% difference to a 9% difference. So we don't get him absolutely perfect, but he is now stable. He is at a good level that he's happy with. And actually, he is not going to get any worse. He's going to stay at that level. So for him, the big win is volume and cosmesis and function. And also, it takes away the worry that he's going to get worse. He's now stable in the long term. So just trying to think about the treatment, you've got your non-surgical... Right, okay, so I'll just ad-lib it. So you've got your non-surgical, which is the mainstay of treatment in the UK, and most people with lymphedema will go and see a lymphedema practitioner who will give them garments and compression, and that's it. You've got your disease. We'll try and manage it as best we can. There are surgical options, which is LVA or lymph node transfer, which I haven't discussed, but these are dealing with a fluid, and you want to catch people early when you've still got something to work with. And then for the later stage disease, you've got liposuction. The other things I'd like to touch on, because these other issues are sort of the patients really are aware of about lymphedema, in that lymphedema is much a psychological weight as it is a physical weight. And one of the reasons for that is that you have your cancer treatment. Everyone is really excited about your cancer. They throw everything at you. Everyone gives you all this sympathy, and you get all this treatment for your cancer. And then people say, look, I've cured you of your cancer. Yeah. You say you've cured you of your cancer, and that's fantastic. That's great. You've cured of your cancer. And then everyone stops being interested in you, right? And then you get past to a lymphedema practitioner who says, I'm sorry, but you've got this chronic disorder that's going to last forever. There's nothing we can do about it. Wear this garment, and then you're discharged. And it's extremely troubling. I didn't touch anything, promise. So there's this psychological weight, which is really hard, really, really hard for patients. So lymphedema is a physical problem, but it's also a psychological problem as well. One of the other things about lymphedema, which makes it really difficult, is that most doctors know nothing about lymphedema, in that they had a lecture at medical school for half an hour on a Friday afternoon, and they were probably in the pub, and they probably didn't listen to it, and their knowledge is really poor. So if you do get lymphedema, you have to take control of it, you have to learn about it, and you have to tell your doctor about it, which is also really hard for the patients, okay? So even oncologists, a lot of people don't understand, and their understanding of lymphedema is what they were taught 30 or 40 years ago, which is totally out of date. There's also... Also, patients hide their disease. So there are 400,000 people in the UK with lymphedema, it is estimated. 400,000 people. And how many people do you see walking down the street with lymphedema? Hardly any. And that is because they hide it. They wear long dresses, they wear long sleeves, they hide their arm away, because every time somebody sees their garment, they go, oh, have you sprained your ankle? And they go, oh, God, no, I've got this lymphedema. Lymphedema, what's that? Oh, it's because I had a cancer. Oh, my God, let me go. And then they're back to their bloody cancer thing, and they don't want to do that every time they meet somebody new. So there's lots of people out there with it, and it is pretty demoralizing, and they hide it away, so there is a lot of people to support you, but you can't see them, can't spot them, they're hidden. The NHS, God love it, and I work 4 days a week in the NHS. I love it. It's a fantastic organisation, but it is a postcode lottery in that there are lymphedema practitioners and people with an interest and doctors with an interest, but not very many. And who you're going to get is slightly random, depending on where you live. And so some people get fantastic treatment and other people are let down. There is a resource problem with the NHS at the moment, unfortunately. The other thing you really need to be aware of is infection. Because infection is the really big problem that's going to put you in hospital and will be potentially life-threatening. And it is also a disaster for your lymphedema because that inflammation causes more scarring, it makes your lymphatics work less well, and you get a stepwise progression in the worsening of your lymphedema. So early treatment of cellulitis is really, really important. And a lot of doctors don't know about it, so you've got to tell them, I've got cellulitis, I need antibiotics now. Because they'll go, we'll give it a couple of days. And that's the wrong answer, you need to treat it quickly. So we've got a website with some information on it, but I would recommend anyone who gets lymphedema, you send them off to the British Lymphology Society and you find the cellulitis guidelines. And if you've got it, you make sure your GP goes and looks at that as well, because that will tell you exactly what antibiotics and when to treat them. And then you should look at the Lymphedema Support Network, which is a fantastic organization like this one, but it's dealing with patients with lymphedema, and it's patients as a charity looking after themselves and advancing things. So that's a really great resource and gives good, accurate, unbiased information about it. Thank you very much.